Thank you so much. It's such a pleasure to be here. Thank you for inviting us. We're really excited to talk to you about utilizing modern real-world data to evaluate care patterns and health outcomes. You'll see from our Flatiron mission, when I tell you a little bit more about what we're about, we're really interested in learning from the experience of every person with cancer. So in way of quick introduction, my name is Greg Calip. I'm a principal quantitative scientist at Flatiron Health. Prior to joining Flatiron, I'm a recovering academic. I was associate professor at the University of Illinois, Chicago for about 8 years. So my background is also as a pharmacist that was working in cancer. And so that's really kind of been my life over the last 20 years of my work. So I'll introduce my colleague, Wendy Wang, my also fellow University of Washington alumni epidemiology. So we're really excited to be here and talk to you about Flatiron data and the kind of work that we're doing. Flatiron Health, our mission is to improve and extend lives by learning from the experience of every person with cancer. And learning from the experience of more people with cancer allows us to gain insights on a better high-level understanding of how cancer works for both researchers and care providers. The examples that we're going to talk about today really kind of are true to this mission. We're going to talk about how the work that we're doing at Flatiron with our data is really related to health equity. And in that way, real world data has that promise and potential to kind of extend what we know in biomedical research to populations that just aren't captured by clinical trials or done inefficiently. So we're really excited to share that with you today. So just a quick agenda here. I'll talk a little bit about the background and methods that we're going to be using, a little bit more about how Flatiron data are created. We're going to do 2 deep dives just pretty quickly. One that's health inequity in treatment and initiation and outcomes in cancer patients. This is actually looking at a wider swath of our data, 20 separate cancers. And then we're also going to look at something really specifically that was presented last year at last year's American Society of Clinical Oncology meeting, disparities in telemedicine use during the COVID-19 pandemic. And then finally, and most importantly, we'll talk a little bit about Flatiron research data access, because that's something that faculty and students here in the department should really kind of explore and think about and see if it applies to your health equity question or another type of clinical question. So the Flatiron network encompasses about 3.5 million active patients, and this represents the experiences of about 2,700 clinicians, 280 cancer clinics, 21 academic medical center partners, and this results in about 800 unique sites of care. So really kind of looking at this, we are nationwide, and when we refer to some of our data that we're going to talk about today, we refer to it as the Flatiron national data. Patients are sampled with different cancers across all of that, but we actually use data from across the entire network for different types of research that we do with Flatiron data. One of the aspects that was important for us to capture when we were thinking about health equity specifically was Flatiron's socioeconomic status index. So this is actually an index that's based off of the Yoast SES Index that's kind of NCI's gold standard. So this is an area level measure of SES that's based on this validated approach. There were a couple of things. This is the first full-scaled social determinant of health variable or index measure that's joined the Flatiron data, and it's at the area level. We did this for a couple of reasons. One, the Yoast index is really well known in the cancer epidemiology space. It's been validated and can be done so at multiple different geographic levels and has been demonstrated, and we can show that it's comparable. I think that we want it to be as transparent and forthcoming as possible in terms of how we represent the SES index. So the SES index validated by Yoast incorporates all of these: income, poverty, home values, rental costs, education, blue collar employment, and unemployment. All right, so the SES index is composed using multivariable factor analysis that characterizes and ranks socioeconomic context of a particular neighborhood. So it takes each of those specific measures, ones that are measure different aspects, the ones that we listed on the previous slide, using American Community Survey census data. So again, this was kind of based on the NCI SEER approach. Couple good things. We know a lot of different area level measures that measure health and health outcomes. Not only is this one maybe well suited for cancer epidemiology, because it's been used by SEER, but it can also be done at multiple different levels. It can account for different things, like if there's missing aspects of these. So imagine in a rural area where there really isn't a median rent to speak of, or that one can use here. We use multiple imputation by chained equations to kind of account for that, and then still able to produce an SES index for all of the patients in our data set. So a couple differences about how SES is measured in the Flatiron data. So this is measured based on a DeGauss geocoding. So it finds a centroid to where patients in the Flatiron network are located. And that falls into one given geographic unit. So for example, a lot of public health research uses zip code tabulation areas, for instance. And so zip code tabulation areas are generalized area representations by the US Postal Service. They have no set standard. They can vary widely, and on average contain about 3,000 people in the population, and there's 33,000 of them. So these are rather large. The interquartile range kind of goes up to 14,000. There are census tracts, and these are relatively smaller, but they are permanent statistical subdivisions. So they were intended to be used for this type of purpose for statistical analysis. They have a designed range, so that's set between 1,200 and 8,000 people, and the median is about 4,000, and there's 73,000 of them. Flatiron uses a census block group, so it's one level above just the block centroid, and these are statistical divisions of the census tract. They have a bit smaller of a designed range between 600 and 3,000 people. The median is about 1,200, and there's 220,000 of them. So again, we're not looking at individual level SES, which is of great importance to us, but we know that where you live matters. And this is taking as close as possible to your neighborhood. And so when we sometimes refer to neighborhood SES, in this case, it's your block group. All right, so when we applied the SES index into the Flatiron data, this was done for the first time. We calculated this, and this is just the variables that were included in the SES index. I think the entire point of the slide is to show that we're give some face validity to what we were showing here. So as you can see, as the SES index is increasing from the lowest to highest, median household income is also increasing, as is home value, median rent, and education index. And as well as you go from the highest to the lowest, there are more folks that are living under the federal poverty line that are working class and are unemployed. This is a snapshot of Flatiron data in 2022. So this is looking on the left at a US population-based weighted quintile of the SES index. So when we calculate the SES index, we did it at the whole US population level. The US index is pretty flexible. You can do it at the state level and then divide quintiles in that way too. We did it at the US population level. Our data are nationwide. So calculating at that level determines the thresholds. And then once we calculate that among our Flatiron health population, we apply those thresholds. And what you'd see here is that it approximately incorporates folks from all across the SES index. So basically, I think the takeaway is doctors in the Flatiron network, oncologists in this network are treating patients from both the highest and lowest SES index quintiles. All right, so I'm going to talk about a presentation. This was actually presented last year at the AACR annual meeting in 2022. So this is looking at socioeconomic status, kind of as we just described it, and inequities in cancer treatment initiation and overall survival among patients with 20 different cancers that were included in the study. And it spanned 2011 through 2022. So we know that socioeconomic status is associated with cancer outcomes, adverse outcomes through multiple pathways. So thinking about that, you want to think about differential healthcare access, the type of environmental exposures and behaviors that kind of correlate with kind of neighborhood SES. And in prior studies, they have tended to look at this question, but maybe it looks at a specific subpopulation. So not all of the different cancers represented here. Maybe they use a less granular level set like a zip code, or they use like unidimensional area level SES measures like income. And that's really kind of failing to capture the heterogeneity across these kind of large geographic areas. And I'll just say too, electronic health records don't do a great job capturing either area level SES or individual level SES. Things like that are changing. There are ICD-10 codes, Z codes that kind of like strike at this, but they tend to not be fully captured in something like the oncology EHR. And so our objective was to examine socioeconomic disparities in the timeliness of healthcare utilization, and specifically real-world overall survival. So this was a retrospective study. This was using the nationwide Flatiron Health de-identified database. It's a longitudinal database. And in total, in these among the 20 cancers that were included, there was 291,419 patients. And these patients all had a confirmed cancer diagnosis of the given specific types. That index diagnosis, and I say index diagnosis because sometimes it's when they had their metastatic diagnosis, for example, between 2011 and 2022, they were adults, 18 years of age and older, had a known biological sex, and they didn't have missing treatment data. So they had enough sufficient information to be included in our longitudinal data set. And then lastly, they had a valid geocodable patient address. So again, they had, through this DeGauss method, somewhere where we could get to their block group and define a centroid so that they could be paired with an SES index value. So the outcomes here are treatment initiation. So this was the first documented receipt of a systemic anti-neoplastic therapy, or for blood cancers, this also included stem cell transplantation. And then we measure real world overall survival in our Flatiron data, which again, that's not perfectly measured in EHR data alone. So we measure it from three sources. One, the kind of unstructured EHR derived data. We use a commercial death data source, obituary data, and then it's also a linkage to the US Social Security Death Index. And based on that and combining those, we have a much higher sensitivity and specificity versus, say, the EHR alone. The exposures here are the SES quintile, and we analyze these using Cox proportional hazard models that were adjusted for clinical characteristics kind of across the entire data set, pretty minimally adjusted: age, sex, ECOG performance status, and the stage of diagnosis. And so these patients were followed from until the event, last confirmed activity, and then the end of the study period. So really quickly, there were demographic differences that were really clear by SES, and none of this is a big shocker. This is kind of what we'd expect. So in higher SES areas, there is a higher proportion of representation of non-Latinx white patients. In low SES areas, there's a higher representation and proportion of non-Latinx Black patients and Latinx patients. Interestingly, there's when you look at the ECOG performance status, which is something that's measured to evaluate patients' fitness for different systemic therapy. In the highest SES index areas, it's a little bit lower representation of the most severe kind of deficits for performance status. And then in low SES areas, it's a bit higher. So for this one, living in low SES areas was associated with a 6% lower likelihood of treatment initiation. This is across 20 cancers, about 12 solid tumors and 8 blood cancers. And the median time to treatment, again, across all of those very disparate kind of diseases, was 48 days versus 45 days. Obviously, when you kind of break it down into the individual disease models, you kind of see some of those more meaningful differences, especially as it relates to, say, the time until surgical treatment. The adjusted hazard ratio here was 0.94, and it was statistically significant. Median real-world overall survival was 8 months lower among patients that were living in low versus high SES areas. Again, this is a relatively lower overall survival. A lot of the cancers that were included here were advanced or metastatic. There was an adjusted hazard ratio of 1.2, and it was statistically significant. And these type of survival inequities were persistent across 19 of the 20 cancer types. If any folks are interested in it, we can share our AACR presentation with you. And this is actually a manuscript that's under review right now as well. We also looked at treatment and survival inequities that, in the COVID-19 era and previously, the same type of survival inequities were equal across both of those periods. So SES was related to lower SES was related to increased risk of death. However, specifically for the treatment initiation during the COVID time period, there was a greater impact than previously on time to treatment initiation, with more delays occurring during the COVID time period. I think we're all moving into an era where we need to kind of subset our analysis on like pre-post COVID and see what was happening. So when we look at inequities that are observed in non-Latinx white and non-Latinx Black patients, we can see that at least in non-Latinx white and non-Latinx Black patients, these trends tend to be consistent. So among non-Latinx whites, the white patients, there's an increased risk of death associated with low SES, and similarly with Black patients. Unfortunately, there's a little bit less representation of Latinx and non-Latinx Asian patients. So those trends and the consistency of the associations is a little bit less clear. So this was the largest and most up-to-date evaluation of socioeconomic status on treatment and outcomes among patients receiving care for 20 common cancers. What you'll notice there is that we kind of really went up all the way through 2022 to do this evaluation. The recency of Flatiron national data is about 30 days. So versus claims data, for example, where there's a lag of about 2 years, you have follow-up and treatment all the way through the most recent 30-day time period. We incorporated a slightly more granular area level SES, the block group level, and we evaluated this by racial ethnic inequities. So some of the limitations, though, a lot of our disease models are advanced or metastatic cancers. So the non-systemic treatment was not necessarily captured in all of them, for example, for surgery, but that often wouldn't be the first line of therapy for some of these cancers. Of course, there's the possibility for residual confounding by missing data and unmeasured factors. And again, the SES is measured based on where people live, the area level, not individual level SES. And this was also based on where patients had the most recent documented address in the EHR. So essentially what we were demonstrating was the feasibility of incorporating an area level SES measure in our data. We think this is just the first and I guess most recognizable, but one of the only first social determinants of health that we think will join the Flatiron EHR data. It was a way for us to evaluate inequities in cancer outcomes by area level SES. And then also, look at just the representativeness of our network. It was just another dimension in order to measure how representative our patients are. Lower area level SES was associated with worse survival, lower treatment rates. And so to reduce inequities in cancer care and survival, there really needs to be targeted efforts to focus on marginalized lower SES neighborhoods and where necessary.
I'm going to talk about the next case study, which is relevant to what Greg just presented, but probably in a more specific research question. And we're looking at racial and socioeconomic disparities in telemedicine use among US patients initiating cancer treatment during the COVID-19 pandemic. This was presented as a poster discussion session at last year's ASCO annual meeting in June. So just for a quick background, I'm sure everybody is quite familiar with that. The COVID-19 pandemic was associated with disruptions in healthcare care delivery, including decreases in in-person clinic visits. There are a lot of clinicians who shifted to telemedicine or telehealth services to mitigate declines in in-person care, as well as to support and prevent the risk for both patients and care providers. Federal and state level regulations were also enacted pretty early in the pandemic to expand coverages and reimbursements for those visits. There's some evidence to suggest that telemedicine uptake may vary by different socio-demographic factors. However, the evidence were quite limited when we conduct this study. So therefore, at Flatiron, we aim to run a study to assess factors, including SES Index that Greg just presented in detail, their association with telemedicine use among cancer patients who initiate treatment across 21 common cancer patients who were seen at community oncology clinics during the ongoing pandemic, COVID pandemic. So just a quick just a quick background for telemedicine visits. Telemedicine wasn't really a thing before pandemic, but in March 2020, during the COVID-19 public health emergency, there was a quick regulatory kind of change in coverage expansion to cover and reimburse for telehealth visits. And also there's also discussion on whether these coverage should be kind of installed permanently or moving forward as well. And these may have huge impacts on care access for different patient subgroups. So at Flan, we were also able to quickly implement that into our business rules. Just gonna give an overview of how we implement and measure or document telemedicine visits in the Flan database. So all telemedicine visits are documented from structured EHR information on billable evaluation management visits conducted by a practitioner. And very specifically at community practices, which compose about like 75 to 80% of our practices, telemedicine visits were defined using a combination of visit information, billing information, and patient documents based on these following two criteria. So either a billing code that's specific to a remote evaluation and management visit, which can be audio only or audio and video, and as well as a natural language processing that's looking at billing code specific to a in-person evaluation, but they have a keyword in the title of the document saying telehealth, e-care, e-visits, or like telemedicine, etc. So as we can see that, at Flan, we were able to document telemedicine visits at scale starting on March 2020 and up to now. And you can see here, the graphs show in non-small cell lung cancer as well as multiple myeloma that the purple line indicates the frequency of the traditional visits, and the blue line indicates the frequency of the total number of visits, including traditional and telemedicine. And the gap in between shows that there was a dip as of April 2020 for traditional visits, where it was partially supplemented by telemedicine visits until the traditional visits start to catch up later in the year. So for this particular study, we have a much smaller sample size because it was focusing on the COVID-19 area. We have almost 27,000 patients who were required to initiate first-line treatment between March 2020 and November 2021. And the follow-up period ends in March 2022. Patients need to have at least 90 days of potential follow-up, receive care at community-based practices, and have a geocodable residential address for SES Index. The main outcome here is telemedicine use, which is defined as at least one telemedicine visit within 90 days after their first-line treatment initiation. And exposure variables here include race, ethnicity, insurance coverage, urban or rural area status, and SES Index. We used logistic regression models to run both unadjusted and adjusted model, including the 4 clinical characteristics that we used in the previous study as well: age, sex, performance status, and stage to examine increase in telemedicine use. Okay, so we just shifting to the results really quickly. As we can, we have about 16% of patients who used telemedicine service by our definition in our whole cohort, and we see substantial inequities in telemedicine use. So, for example, we see Black patients, the frequency of telemedicine use was about 13% versus almost 16% among white patients. A particularly jarring difference here is the lower right graph here, that we can see about, about 1 in 4 patients who live in the highest SES index area have used telemedicine, compared to about only 10% of patients living in the lowest SES index area have used telemedicine, suggesting, there might be expanded inequities for access to telemedicine use during the COVID period. And these inequities remain statistically significant after adjusting for clinical characteristics, including, for Black patients, patients with known or unknown insurance status, lowest SES, as well as patients who living in suburban or rural areas. The statistical significance remained the same after adjusting for clinical factors, suggesting that clinical characteristics don't really explain or fully explain the inequity that we're seeing. These are just like more detailed, showing from top to down 4 different cancer types, and we see the trends remains the same. So it's from top to down is advanced non-small cell lung cancer, metastatic colorectal cancer, metastatic breast cancer, and metastatic pancreatic cancer. The significance level does change a little bit by each cancer type. For example, For pancreatic cancer, a lot of metastatic pancreatic cancers, patients are very sick and their chemotherapy might be very toxic. So they may not be good candidates for telemedicine use to start with. There's some disease-specific differences across different cancer types. In addition, we have observed that telemedicine use was the highest, almost 25% at the beginning of pandemic, so March to May 2020, and slowly declined later down for patients who initiate treatment, later during the pandemic follow-up period, down to about like 12% at the end of tail end of the follow-up. So a lot of strengths and limitations are very similar to the study that Greg just presented. I just want to point out this is a relatively large study. And also this is a nationwide study that focuses on patients who receive care at a community-based clinics, which I think a lot of which it takes care of a lot of cancer patients in this country. The limitations are, of course, there are always missing data and potential unadjusted confounding that might, have affected the observed inequities, most likely due to lack of documentation of care received outside of our network, as well as our SES Index is area level based instead of individual level based. But in sum, using this real world data, we see that about 1 in 6 patients who initiated cancer treatment used telemedicine service during the COVID-19 pandemic. We also observed that Black, uninsured, non-urban, and patients living in lower SES Index areas were less likely to use telemedicine services. And we also seen that telemedicine use has declined over the course of pandemic, but inequities persisted throughout the pandemic. We think these findings are very important considering recent efforts to make the coverage of telemedicine service permanent and to increase reimbursement rates for telemedicine services by Medicare and several Medicaid programs and private insurers. But we do believe that the proliferation of telemedicine services may widen cancer care inequities if people of color and those who live in marginalized areas do not have equitable access to telemedicine use. So we think future studies should examine additional SDOH characteristics that may be associated with telemedicine equity, such as access to high-speed internet, language preferences, etc., as well as whether healthcare delivered via telemedicine is of similar quality as in-person services. We would also like to learn which practices are providing telemedicine more equitable to the patient, so we can bring this learning to benefit the rest of the network as well. So UAB has been our academic partner since 2018, and all UAB faculty, student, postdoc, and research scientists have access to all these 3 data sets, which is National Enhanced Data Marts, which was the data set we used for the previous 2 studies. Also National Clinical Genomic Database that I briefly mentioned, as well as local data, which is identifiable to UAB users, where you can use it to link it to the other patient cohort data you have locally. Local data it can be accessed through UAB Data Warehouse, but I do not oversee the access to that local data. And I'm going to focus on the access for EDMs and CGDBs, which are both accessed through Flatiron via a proposal-based process. So this proposal-based process are all handled through the Flatiron research platform called Flatiron Explore. And you can use the QR code here if you don't already have access to it. It's an easy, quick, short Google form to sign up with your UAB email address. You'll get an email to kind of initiate your access to it. And everything involving in the whole proposal submission up until data delivery, etc., are handled through this platform. So in general, we encourage investigators to kind of take a look at the platform because it also has a knowledge center, which has tons of content about how we derive each variable within each table, disease-specific tables, as well as methodology tutorial and the guidance, etc., all the considerations that we know about our data, limitations and strengths for you when you're considering or forming your research questions. And once you're ready to submit a proposal, Flatiron conducts a feasibility review. It's a monthly base. We just review we group every month and review the feasibility, mostly to see is this research question answerable using Flatiron National Dataset, given what we know about the Flatiron National Dataset. And once all the feedback is resolved between a PI research team and Flatiron, we'll send it to UAB steering committee for review and approval, and followed by IRB and statement of work contracting, and data delivery will happen shortly after that. And a research team usually have about 1.5 to 2 years to have data rights to conduct the analysis, publishing, and everything. Would you require to see a draft of any publications coming out of the proposal, mostly to provide a proper language and references for data characterization, and just to make sure you did what you proposed to do. You didn't go wild and outside the proposal. We do require a 2-week review because it's not just us, it's including our publications team who will usually provide a standard language for publication as well.